Okay, we've got a good topic today. Heart failure with preserved EF, and I will go over our learning objectives here. Oh, I think I will.
I think there was an extra slide for some reason.
Uh-oh.
There we go.
Uh-oh. Okay.
Oh, there it went.
Oh, there we go. Hey, that's good technology. I'm being too impatient. Understand differences in treatment of heart failure with preserved ejection fraction versus left ventricular dysfunction heart failure. Understand the morbidity and the mortality risks. And then apply the art of medicine versus the science of medicine, because frankly, this is an area where there really isn't a lot of evidence to guide you. So Dr. Birch and I have been saying that's what we really want people to start learning about this, and of course you'll be experts at it after 10 minutes. So.
Yeah, and one article.
That's right.
Should we start with the case?
Yes, please do.
And this is a fairly typical kind of thing. 73-year-old with rate-controlled atrial fibrillation presents to the emergency room with shortness of breath. Chest X-ray shows edema, and the exam is kind of limited. The BMI is 45, and sometimes it's hard to hear lung sounds and get JVD on these people. Kidney function's normal along with the EF and the E to E prime, and the PA pressures, the pulmonary pressures are slightly increased. And so what's the next best step for this person?
Treat the underlying cause and diaries.
So
Very good.
And I think the hardest part, and I think why folks struggle with this, is making the diagnosis.
Yeah.
Of what's the underlying cause, right? Because they have atrial fibrillation. Yeah. They're obese. Maybe it's obesity, hypoventilation. Maybe it's
OSA.
Yeah. There you go. And
our tests don't work, so natriuretic peptide may be not helpful. Chest X-ray is normal 30% of the time. So that again is like where you got to really kind of be thinking of your differential and figuring out what it is. So.
And so when you have a hard time characterizing it, that makes it hard to study, which means that our understanding is limited. So I was just going to mention what I usually do is just, and I think the article mentioned it too, is go back through the history. And what fits best.
Right.
People with atrial fibrillation, the ones I've had that have symptoms, that can be difficult to sort out, but they don't usually have pulmonary edema.
Right.
And sleep apnea, sometimes they can, but not typically, and so you kind of have to go with what's the best fit. And the BNP may or may not be elevated. If you're obese, there's about a 30% chance it will be normal.
Right, the test you rely on, and then you just like rule out MI, and then you're like, okay, you're good, go home. Follow up with primary care.
Exactly. And I think the other thing that's tough is, I look at the echo, but what do you have to do on the echo? What's important? You really have to dig through the numbers.
You do.
You have to look at the LV thickness. I look at that, the E to E prime. Look at the pulmonary pressure.
Because otherwise, you see preserved ejection fraction.
Yeah.
And you walk away. And what is heart failure? What's the definition of heart failure? Let's try to think this through a little bit. So, and once you think this, I think that there's a lot of times I take stuff for granted, and that doesn't help me when I'm trying to apply the art of medicine. So heart failure is the inability to preserve or to send blood to complete all your essential metabolic functions, right? So here's a person with heart failure with preserved EF. It's almost, that doesn't make sense. But what's the difference? Where is the heart failing when you have a preserved EF?
Relaxation.
Yeah, relaxation. So it's diastolic failure versus systolic failure. So that's where you got to start thinking of your underlying mechanism. And we get kind of used to treating and diagnosing left ventricular systolic dysfunction, but not diastolic dysfunction. So
yeah, and the article mentioned this, and I think it's what I've seen in practice is that the heart failure with preserved ejection fraction is more common now. We've gotten so good with medications and stents. I don't have a lot of folks, I used to have a bunch who had low ejection fractions. So that is less common now. Interesting, mortality is almost the same.
it is.
Slightly better if you have preserved ejection fraction. You're more likely to have something else go wrong, die of something else, versus if you just had isolated systolic dysfunction, but very high mortality. And I find that a challenge because it's hard to talk to patients. it's really easy when their EF is 5%.
Right.
About, palliative care, end-of-life care, that sort of thing. So,
It's real interesting because I think actually what leads to diastolic heart failure versus systolic heart failure is a different remodeling. And it's the diseases that lead to remodeling, diabetes, hypertension, that's getting more prevalent, which is why I think we see more of that. But it's still an abnormal reaction to something going on. Instead of getting the floppy heart, you get too much of a muscular heart. So again, but I think when people look, the name's wrong, preserved EF. The name is wrong because then we think, oh, there's not as much mortality, it's okay, there aren't,
yeah.
I mean, it almost leads you down a bad path.
Can I vacillate on
Please
this?
do.
And then we'll move on to treatment. So,
You have a captive audience after all.
They're being tortured.
Yes.
And is anybody here had it where you look at the echoes and they've had 2 or 3 echoes? One says diastolic dysfunction, the next one doesn't. Oh my gracious! It makes you want to pull your hair out. It's just the cardiologist. What's wrong with them?
What is wrong with that?
It's just hard, right? It's very much up to interpretation. This E to E prime thing. I talked to my wife. She does these intraoperative echoes. It has to do with how the wall moves, so it's very subjective. And then, so it's just difficult to diagnose. And there's no substitute for good history and exam. And
I don't think heart failure with preserved EF gets better. It goes away, so you can't trust the echo.
Yeah, it's not like, I think if I were to pick, I think I would choose to have low EF. And because you have a chance at recovery. Because you can do things. And what about medications that we use in systolic heart failure? Do those things do anything for those with this condition?
Not besides diuretics.
That's right.
That's
and
right.
The diuretics, what do we do with those? We're not changing natural history. We're just treating symptoms.
And that's true of every medication we have in our toolbox right now.
Yeah.
Is that it does not make you live longer like it does with systolic dysfunction.
Yeah.
And some of that, then where I challenge you though is to look at when you're trying to treat a patient is, okay, is there lack of evidence, meaning maybe I should try that when other things aren't working, or is there evidence that it doesn't work?
Correct.
So looking at like ACE inhibitors, good studies, doesn't help. Don't
Yeah.
use it.
Unless they have another
Right, unless they
for
got
it.
renal failure or something like that, But to me, in this disease, the benefit risk changes markedly so there's a lot of benefit of risking hyperkalemia when you have systolic dysfunction. There's absolutely no benefit to risk that here in this disease. And the same thing with anything else, like bradycardia, syncope, all those kinds of things that we look at as side effects that we have to do that for, so.
Yeah, and speaking of syncope, so the cardiologists love the blood pressure to be, and I always joke, 1 point above passing out, right?
Yeah, they do.
And that is all.
And that's a hard thing to do.
It is. And that's how we treat the systolic dysfunction. But what about these folks with preserved EF? What's their blood pressure goal? Because they tend to be pretty hypertensive as a group. And I think the article recommends if you have chronic kidney disease less than 140, and that's probably about where you'd want most people. But there's no evidence to get any lower.
Right, and then they're always back to that 150 over 90 if you don't have kidney failure, so.
Yeah.
And again, probably no benefit.
Yep. And the one that shocked me for no benefit, that's a little bit controversial, is spironolactone, because it allegedly has these antifibrotic effects. We think the fibrosis is part of it, but it didn't change things.
Right.
And it's just so interesting because just a dash of spironolactone in systolic failure makes a big difference for people, but not the case here.
Beta blockers, same thing, but less studied, I believe. That's one where it's like maybe useful to try because they haven't proven it doesn't work. So it's always important, I think, more and more we see lack of evidence, meaning we shouldn't do something.
Yeah.
And that isn't necessarily true. So you just have to kind of patient by patient.
Should we? I don't have anything else other than.
That's it? That's all you're going to tell
That's
them?
all
What
I
about
got, man.
statins? You're going to tell them about statins?
What do you guys? Everybody should be on a stat. Well,
Well, it's true. I forgot mine today, but I'm going to
statins did have lower mortality, but it's unclear if it's cardiovascular or just in general. So,
Yeah.
and when I kind of saw that, I thought, these people tend to be obese, diabetics, hypertensive. They're probably going to be on a statin for other reasons.
Yeah.
I had a hard time thinking of a person I might have seen that would have preserved ejection fraction and not have all those comorbidities and started a statin on them for the reason for
Right.
for that particular reason.
Right, it's a good reason. Nitrates, big vasodilation, probably harmful. The other thing is that these people share characteristics with other people with risk for sleep apnea, and so that's a good one. And there may be dysfunction getting created or remodeling if they have sleep apnea.
Yep.
And I think one of the few things that the article really emphasized was where you can get confused with this diagnosis is like epicardial ischemia. And so a stress testing should also be
agreed.
done a lot. Because these people, they actually have okay function when you're echoing them on the table, but once they get up and walk, that's when their real
And
problems
a
occur.
good chunk
So it's
of them
exertional.
a good chunk of them are diabetics.
Yeah.
And so they may not have typical angina symptoms. And so when I do the workup, I typically do a stress test
Right.
at least once.
I think it's important.
Yep.
So. Okay, now I will let you be done. You're done. Key points. Heart failure with a preserved ejection fraction is a failure of diastole versus systole. The benefit and risk of treatment is very different. Natriuretic peptide levels are not as useful in diagnosis and may be normal multiple times, even when they're in heart failure. And treatment includes diuretics, exercise, and disease management programs. And again, tailoring to your patient to what improves them. So
Questions, concerns?
everything you needed to know.
How would you guys treat the lady in the vignette? Lady, or I guess I didn't say man or woman.
You didn't.
I think it was saying in the vignette.
AFib.
Diuretics, rate control,
Yeah,
weight loss, sleep it.
yeah. If this was
Study.
Yeah.
if this was a first presentation, I would probably do a stress test after they've had diuresis and are stable. Probably do monitoring while they were in the hospital to make sure that they're not RVR and that's
Yeah.
what's going on. But rate control and diuretics, and then
Statin.
sleep statin and a sleep study, and that's
Yeah.
that's about it.
Yep. All right.
All right.
Very good.